Okay, so my name is Ina. I'm a consultant in anesthesia and intensive care working in Zagreb in Croatia. Changed many locations in my life, so this is the, the current one. I want to thank Melissa and Abdullah for this kind invitation and for this lovely 2-day lectures back to the basics. I don't know why it doesn't go. Okay, so I have no kind of interest for this lecture. What would I like to say at the beginning, that experience in medicine is actually, the definition is an ability to make a mistake repeatedly with increased confidence. That's why we need more confidence in what we do in our daily practice. Related to this topic, I would like to point out the complexity of cardiovascular function. It's related to autonomic central and peripheral nervous system. It's related to endocrine paracrine mechanisms. It's related to cardiovascular system per se, to renal system. What we do daily is actually we are measuring or noting hemodynamic response to pathophysiology, and our medical interventions are related to each patient, trying to target individual therapy. We are lucky since in today's world we have a lot of methods and devices, but what is most important is accurate measurements and interpretation. You all know that by task force of European Society of Intensive Care Medicine, there was a consensus on circulatory shock and hemodynamic monitoring, where they suggested the use of transpulmonary thermodilution or pulmonary artery catheterization in patients with severe septic shock, especially in those ones who have associated acute respiratory distress syndrome. Transpulmonary thermodilution technique, instead of these sepsis and shock syndromes and pulmonary edema and lung injury, are used also in trauma births, but also in any condition that requires assessment of hemodynamic and or volumetric function. As you know, physiological relationship, the arterial pressure is the product of the combined effects of the blood flow ejected by the heart and arterial system, which compromise both actually the mechanism properties of the arteries and the effects of arterial wear relationships. When we have arterial pressure waveform analysis and we have to have derived stroke volume, it actually analyzes aim to estimate the stroke volume from the arterial pressure, so that the arterial system must be characterized to establish a valid pressure volume relationship and reliable stroke volume estimation. Externally calibrated methods of arterial pressure waveform analysis is transpulmonary dilution method. We have on most two devices, Pico and volume view, and transpulmonary leaching dilution for the clinical monitoring. Transpulmonary dilution is a technique for hemodynamic monitoring. It consists of a monitor device which has two catheters. One is in, I would say, in superior vena cava, it can be in another vena, and thermistor tipped arterial catheter, which actually allows us to measure blood temperature. The cold indicator, if we use them, is being detected there in systemic artery, and after he passed through the right heart, the lung, and the left heart and the aorta. Transpulmonary thermodilutions allows us the computation of cardiac output from the thermodilution curve based on Stewart-Hamilton formula, as we see on the left side, where we have this Stewart-Hamilton principles related to pulmonary artery catheter and to transpulmonary thermodilution. Transpulmonary thermodilution curve has longer appearance times, has a lower maximum temperature change, and a longer return time to baseline temperature when we correlate it with the pulmonary artery. What we have from TPTV is it provides us with several important hemodynamic variables. So from transpulmonary thermodilution, it calculates volumetric measurements of preload and cardiac output. And on the other parallel, we have pulse contour analysis that provide us with the continuous cardiac output and stroke volume variation. Stay on the side of the transpulmonary thermodilution notice that we can have. So we can continually evaluate global preload markers as the global end diastolic index and interthoracic blood volume index, or we can monitor pulmonary edema using extravascular lung water index, which actually tells us about volume of pulmonary edema, or pulmonary vascular permeability index, which tell us about the capillary leak. And of course, the contractility with cardiac function index, and the global ejection fractions, which are the parameters of global cardiac contractility and the fraction of the preload volume pumped in 1 minute. What is most important, and we always go back to that, because when we have different tools and different monitors that we can use today. But we always have to be sure that the monitor and the tool we are using really properly. Otherwise, we will have misinterpretation, and we will have a misdiagnosis, and we will have therapeutic treatments. So just a quick note, we have to have assessment of arterial pressure curve and rapid flush test. We have to see, is it zeroing the pressure transducer? Are they entering accurate patient's demographic data into the monitor? Entering the central venous pressure. Here it serves for calculations through systemic vascular resistance. We have to adjust indicator volume. It is the amount that is usually represented on the monitor when it's listed by these all data. Effect of injection site also close to the patient as possible, so that the measurement will be more accurate. Effect of injection speed, it should be fast and steady through some 8 seconds. Of course, during this calibration, we have to do observation of transpulmonary thermodilution curve. It has usually, normally, flat portion reflects the mean transition time of cold injected from injection site to thermistor. Then it rises and falls delta temperature, and as an exponential decrease. And again, the end in plateau, which is physiological recirculation of the indicator, and we call it the downslope time. What is acceptable precision in terms of PICO, if we are taking 3 measurements and we use measured values that should not deviate more than 13% from the mean value, so that we can say it is adaptable calibrated. What is also we should take into account, now when we know that we done something properly in mechanical way, we have to think about the patient, we have to think about the diagnosis, the pathophysiological issues, and we have to taking that into account with transpulmonary thermodilution data that can be provided. So we have to check for shunts. Is there any left to right shunt? TPD curve was just a sorry. If the indicator will go more rapidly reach the tip of thermistor, and we will have overestimate cardiac output. In contrary, in left to right shunt, remixing of injectate with in ITTV will underestimate cardiac output. We have to think about catheter position, because pulse increase of volumetric parameters is seen if venous and arterial lines are both, for example, on the femoral side and on the same side of the body. If there is a continuous renal replacement therapy, by some studies will show that small statistically significant decrease in cardiac output index and the global end diastolic volume, and it was shown an increase in extra volume lung water. We also have to make a note on heart valvular disease and function during the interpretation of TPDT. Because the aortic stenosis, we will have possible increased volumes that may differ at each measuring and recalibration, and with mitral valvular station, we will have a consistent increase in the volumetric preload parameters. thinking about pleural infusion. Pleural infusion will not increase TPTD, which is derived from extravascular lunge water. If extravascular lunge water index is normal and we on X-ray see some opacities, then we should check it with ultrasound to see if there are any pleural effusion. What is important are normal values and indexation. They are predicted. It's shown that predicted body and there are predicted body surface area when they are used instead of actual one, improved accuracy in obese patient and better correlates with severity of illness and survival in acute lung injury patients. We have to know that patient got in his medical history pneumatictomy because correct calculation of global and diastolic volume is still possible while the extravascular lunge water is underestimated. Of course, majority of patients in intensive care units severely ventilated, so it may decrease EVLV by concomitant decrease in cardiac output and pulmonary capillary pressure, or it may increase, on the other hand, by reducing the lymph flow and the pulmonary interstitial pressure. Also, what is possible that we have patient with pulmonary embolism or RDS due to microthromb and or high P. Then extravascular lunge water is underestimated. I should also mention patients with arrhythmias that are actually not suitable for this kind of technique. This is just a short scene how parameters that we measure in thermodilution techniques can actually guide us in therapy. Meaning as agent drugs. About transpulmonary thermodilutions was a lot of papers done by a French group led by Jean-Louis Teboul and Xavier Monet. And here is one scheme from their transplant advantages and limit paper. It shows what are these differences we have with transplant thermobility index is different hydrostatic pulmonary edema and RDS, and it indicates the risk of pulmonary edema per se. We can measure the extravascular lunge water, which increase in case of hydrostatic pulmonary edema and RDS, and quantifies the volume of pulmonary edema. I will not talk so much about stroke volume and pulse pressure variation. It was already much said of it, but what should be cautioned here is that patients should be sedated and mechanical ventilation with no spontaneous breathings, and to say under so that we can interpret it for the therapeutic issues. This is also another slide which shows us what is very important always to think about main advantages and main drawbacks about all the data we can collect from the transpulmonary thermodilution. Does it mean extravascular lunge water? We have to think it's reliable in case of pulmonary embolism, lunge exsection, or if we are chasing for global and diastolic volume, we have to see that it does not distinguish between the right and left ventricles, and less directly reflects the risk of pulmonary edema than with the pulmonary artery catheter. I will show you just a few studies that show the use of transpulmonary thermodilution techniques in daily practice in critical patients. So this is led by Xavier Monet. It is a retrospective study that had 200 consecutive RDS patients, and it was looked overall 28-day mortality. Maximum value of extravascular lunge water index and pulmonary vascular permeability index reached during RDS episode are shown in this study as independent risk factors of 28-day mortality. Validation of transpulmonary thermodilution variables is also very important in hemodynamically stable patients, but with patients who have heart disease. So here's one study made by Maggiore. They assessed the validation of cardiac outputs, global end diastolic volume index, global ejection fraction and cardiac index function index, and extravascular lunge water index. They had 3 groups of patients, patient group with aortic stenosis, with moderate to severe aortic stenosis, with dilated cardiomyopathy, and control group of patients. And they actually measurements were performed during coronary angiography. They used left ventricular angiography, pulmonary artery catheterization, and thermodilution using the PICO system. What it showed that actually the cardiac output was similar in all 3 groups, in controls, in aortic stenosis and dilated cardiomyopathy, with good correlation between transpulmonary thermodilution and pulmonary artery catheter using the PIC method. Also, patients with aortic stenosis, but not those with, as we see downstairs on the diagram, a patient with aortic stenosis, but not with the dilated cardiomyopathy, had higher extravalvular lunge water index than control group, while there was only a trend when it was used pulmonary artery catheter and pulmonary artery occlusion as a variable. And the vascular lung water index is probably a sensitive marker of subclinical pulmonary edema. It is particularly in patients who have elevated left ventricular filling pressures, irrespective of differences in their left ventricular function. Here we have in the same study shown that left ventricular and diastolic volume was normal in controls and in the aortic stenosis patient, but was significantly higher in dilated cardiomyopathy patients. Global and diastolic volume index did not differentiate between the patients with normal and patients with enlarged left ventricular and diastolic volume, which is very important. And there was no difference in the global ejection fraction and cardiac function index between patients with normal and patients who had reduced left ventricular ejection fraction. There is also a study that shows the analysis of transpulmonary thermodilution technique in patients with renal replacement therapy. It is a study that showed, that measured, had 20 measurements series formed in 12 ICU patients, and determining cardiac index, intrathoracic blood volume index, extravascular lunge volume index. All that was happening during renal replacement therapy with the blood pump stopped and flows of 100 200 millimeters per minute. On the right side, it has to be pointed that heart rate and mean arterial pressure remain unchanged between measurements taken with the renal replacement therapy blood pump stopped or running at either 100 200 millimeters per minute. What we see on the right side is that cardiac index and intrathoracic blood volume index measurements were significantly lower with the blood pump running both at 100 milliliters and running at 200 millimeters, but the extravascular lunge volume index was higher. Hemodynamic measurements during renal replacement therapy must be interpreted with a good caution, especially when using dialysis catheter, since for injection of thermal indicator or when we have a venous injection and anterior detection site are very close proximity. Some notes for the end. In our daily practice, actually, what is most important when, no matter what device we use, is to set the targets, to know the normal values of healthy individuals, but to know the values of critically ill patients. Best device is actually a device that is used most most frequently, that we know and that we use on our daily routine. Using this device, we can choose the therapy decision, combining different variables that brought up to us. If patient does not benefit from intervention, doesn't mean is it fluids or vasopressor, we should stop it and reassess. And of course, always get the right picture of the patient and his clinical condition. Thank you.